So I think we can start the proceedings, and we are well within.
Just a minute. We'll be starting. So can you start?
Yeah. Yes, yeah. Absolutely. Let's start.
So thanks everyone, and the today's session is going to be very much interesting for everybody. And to begin the talk, let me first introduce all our esteemed panelists and the speaker. So the thing is that why we have chosen this topic, because most of the time this is one of the important topic where by the bedside echocardiography and by the hands on the echocardiography one can able to diagnose and obviously detect lot of clinical troubleshooting. So that is the reason, and that's the reason I have requested Dr. Vivek Kumar. So Dr. Vivek Kumar is our esteemed speaker today, and he's basically the area of interest is echocardiography, and probably I think that is why he's the best person to talk in this forum. So I welcome Dr. Vivek Kumar. Dr. Vivek Kumar is the Associate Director of HN Reliance Foundation Hospital, and we are actually working together a few years back. So we are fortunate to have him here. And with us, the other panelists are I think Dr. Swarna Deepak from Hyderabad. He's working in the consultant intensivist from Hyderabad Apollo Hospital. And with him, our other panelist, Dr. Neeraj Tyagi. Dr. Neeraj Tyagi sir is from Gangaram Hospital. So we are happy to have him here, and we definitely like to have some input from him also. With us, my fellow colleague, Dr. Subhadeep, but he's a little bit sicker today, so he's not able to join. And with this, I hand over Dr. Akhilesh to introduce Dr. Pradeep sir, who is also an eminent speaker and one of the active member of different such type of forum. So Akhilesh, please introduce.
So yes, thank you, Dr. Gunadhar. It's indeed a great pleasure to conduct such programs, especially for the DNP training students and IDCCM students. And we have all the stalwarts today. Dr. Vivek Kumar, he's the only certified critical care physician with the 2D echocardiography diploma. So it will be worth watching him and listening him today. And welcome, Dr. Vivek. I also welcome Dr. Pradeep DeCosta. He is also one of the pioneer in ultrasound and 2D echo. He is associated with the KM Hospital, and we will be able to hear from him as well today. A lot of fundamentals will be cleared up today. And we have other panelists already introduced by Dr. Gunadhar. So without wasting time, let me invite Dr. Vivek to start the proceedings. So over to you, Dr. Vivek. Thank you very much.
Thank you, everyone. Thank you, Akhilesh. Thank you, Gunadhar. There was a time we worked together, and I think most of the loops are from those times. So good evening, everybody. My talk here is basically aimed to improve your understanding of hemodynamics at the bedside by improving your understanding of the physiology of what is going on. And the tool which you will be using to understand the physiology and improve your clinical working will be echocardiography. Now, most of these terms, they do not come into any chapter as such. Okay, they are basically physiological connotations of ICU syndromes Okay, so this talk is based in a little, I will say, in a like a cross-sectional study. We will go through different facets of patient management. So the talk outline is, first we discuss what is the echocardiographic syndrome of acute cor pulmonale. Then we look into an echocardiography based understanding of ventricular interdependence. And then we see the varying relationship between intraventricular pressures and volumes, that it is not that every time the pressures are increased, then the volumes are increasing, or if the volumes are increasing, the pressures are increasing. And then, of course, in the last few slides, I have summed it up to how to manage it at the bedside. So we look at the first case, and that is acute cor pulmonale. Okay. I mean, this is a standard apical four-chamber view in a patient who's come with a cardiorespiratory compromise. And prima facie, if you look at this apical four-chamber view, I mean, there is no doubt that the right atrium and the right ventricle are dilated. Okay. The other thing which we must see whenever we find that the RA and RV are dilated is that we look at the interventricular septum and we just try to see whether this septum is moving with the left ventricle or it's not moving with the left ventricle. But to keep it very simple, you can find that the septum is not moving as fast as the free wall of the left ventricle. Now, whenever you get such a picture in the intensive care unit, you know, the first diagnosis which comes, because in mind is the syndrome of acute cor pulmonale, which basically means an acute pressure overload of the right ventricle. That's it. So somebody has put a brake on the right ventricle output, and therefore the RA and the RV, which are very thin chambers, they just distend. Okay, this is as far as the first slide goes. And this is the role of echo. If you look at the X-ray of this same patient, I mean, I don't think you can get any insight into what is happening with the patient. Nothing meaningful. We move on to another case. This is a case which again came with a cardiorespiratory compromise. In fact, this patient had just a resting sinus tachycardia, and it was about 120 per minute. He got admitted in the evening and we saw him next morning. So this was a resting sinus tachycardia. And if you look, this is a parasternal long axis view. But even for the beginners, if you see, this is the left atrium, this is the left ventricle, this is the aorta, this is the right ventricle. This part of the right ventricle, which appears in the parasternal long axis view, is known as the right ventricular outflow tract. But if you try, even with a slight, even if you are a beginner, you should understand that the right ventricle never looks so big and prominent. It's always the smaller baby to the left ventricle. And the second thing is, in the right ventricle, you can see somebody waving a flag or raising a hand over here, which is a hyperechoic, it's a lobulated, it's a mass which is generally attached to the interventricular septum. Okay, so from this image, I know that the right ventricle is dilated. Then when I look at the parasternal short axis view in the same patient, okay, and please look at it very, very closely. I'll try to freeze the image and see if we can. Okay, so this is the left ventricle, this is the right ventricle. This is the short axis view below the mitral valve level and above the papillary muscle level. And what you can see is that the left ventricle fluctuates between becoming an O and becoming a D. So sometimes it's an O, sometimes it's an D. Okay, and now I'll try to freeze the image and show you. So if you see this here, the left ventricle is a D. This is a D. Okay, this is a D. It is small and it's become a D. And if I unfreeze it, and now you see it's become an O. Okay. And this is the right ventricle as it is. Now, between the right ventricle and the left ventricle, this is the interventricular septum. So this is one of the views I think every intensivist should know how to produce and capture. The most important thing of this view is to look at what is known as the flattening of the interventricular septum. So if your ICU patient is typically healthy, the left ventricle will always be an O, whether in systole or in diastole. That means when you see the smallest size of the LV cavity, that is the end systole, it will be O. When you see the largest size of the LV cavity, that is end diastole, it will be O. But many a times you find that this LV is not an O. It becomes a D, and it can become a D in either systole or diastole. Okay, so in this image, we are seeing that the D basically comes in end systole. When the LV is the smallest, it becomes a D. So my interpretation of the image is that there is a flattening of the interventricular septum in end systole. Okay, and for those of you who are taking the boards, to objectively quantify this flattening for the purpose of exam, nobody does it in real life, is we use what is known as the eccentricity index, whereby we take the two diameters. One is a D1, that is from the interventricular septum to the free wall of the left ventricle, and other is the D2. So D2 by D1, if it is equal to 0, that means LV is an O. But if the interventricular septum slips into the LV cavity, obviously D1 decreases and D2 by D1 becomes more than 1. So if D2 by D1 becomes more than 1 and it is seen in end systole, it has a separate implication. And if it is seen in diastole, it has a separate implication, which we will see in the successive slides. This is the same patient, and this is a short axis view at the aortic valve level. Okay, this is the RA, this is the tricuspid valve, RVOT, and here's the pulmonary valve, and this is the main pulmonary artery. I will just say, and this is the right pulmonary artery, it's more prominent, when you are doing, and if the pulmonary artery appears so prominent, just have a second look into this. And here in the same main pulmonary artery, if you see here, you have on near the tricuspid valve, you have again a mobile.
You have gone into mute mode, I think. Dr.
I
Vivek.
have not muted. The host has muted. Okay. Hello. Hello.
Yeah,
Yes.
now,
Yeah, the host had muted me. I have not muted. So can you hear me?
yeah.
Yes.
So if you see that there is a mobile, there's a clot which is, moving on. It is just swinging and swinging across the pulmonary valve. This is very important. Like this particular case, by the time we did it when all of three of us were together, but by the time I finished the echo and I was calling up the primary, who still is a colleague of Akhilesh and Gunadhar, the patient had one big grunt and he had a asystole flat,
Yeah.
so nothing much could be done about it. And there was another patient I saw at one of my previous centers who came like this, and we thrombolized him, and after the lysis the clot actually disappeared. So these are very important things, both diagnostically. Here I am just discussing the diagnostics, and later on we'll discuss the therapeutic. So this is a clot in the main pulmonary artery, and I'm telling you, by God, you see it. It is not that you, even a beginner, if he can image it properly, will see it. Now, since all of us start with in life by doing subcostal views, this is how it looks in the subcostal views. So in the subcostal view, this is the RA, this is the RV, and you can see a huge clot going across like a jhula, like a swing. It's going across the tricuspid valve. Okay, I mean, this is sine qua non. There are no two ways about it. If you change your angle of probe, the size of RA, RV can change, but please memorize this image. There are no two ways, because these images are not compatible with life. You forget risk stratification, forget. If you see this image, it is a red flag. The matter has to be escalated. I have not deliberately kept an image of the IVC because I don't want the discussion to go anywhere else. So now we come back to the one of the most important take-home messages. If you have a D-shaped LV in diastole, it's a volume overload of the right ventricle. And if you have a D-shaped LV in systole, it's a pressure overload of the right ventricle. Be very clear. So if you are getting somebody who's coming in with a suspected venous thromboembolism, okay, or somebody who's been ventilated for ARDS for about a week, you will typically see that this D comes out in end systole. However, if you're getting a patient of ILD who's got a clinical, not a core pulmonale, or ILD with a right heart failure, or COPD with a core pulmonale, or COPD with a right heart failure, then you will find that the D will be present in diastole as well, maybe in systole, but it will be more prominent in diastole. So this is as much as echo can tell you about things. So acute core pulmonale to an intensivist, if you get this echo, the acute diagnosis is pulmonary embolism. You need to rule it out. So if you see the dilatation, no clots, then you please remember that you need to do a venous Doppler of at least the femorals and the popliteals. And in case the patient is a dialysis patient or a cancer patient with a chemo port, just look at the axillary, the subclavian, and the jugular veins also, please. I mean, this is what you can do at the bedside, because if you find a clot, at least you can go ahead with the treatment of either a lysis or an anticoagulation, because the patient may not be fit to shift to a CT scanner. And if you don't find something, then the patient will have to be shifted to the CT scanner, which is a headache in itself, because the patient may crash, may need intubation and additional resources. The second is ARDS. So most patients of ARDS develop pulmonary hypertension. So the incidence of acute core pulmonale is 20% in cases of ARDS, as far as the EDEC MCQ goes, based on a paper by I think, Michel Slama. And of course, one of the common causes of acute core pulmonale is inappropriate ventilator settings. So actually, if you want to see how it happens post-operatively, you can, if you see patients who come in with tidal volumes, say 600, 650, depending on the choice of the anesthetist, or PEEP of 15 and 16, these are the times when you will find that this interventricular septum is denting into the left ventricle. Always remember that there are other causes of interventricular septum not moving properly. So it may become an O and it may become a D, but sometimes you will find that it is neither a O or nor a D, and it just keeps dancing in between. So typical causes of bouncy interventricular septum for the intensivist is a pre-existing or a new left bundle branch block, or when you have put a pacing wire in the right ventricle, or the patient per se has been has got a permanent pacemaker insertion done. Looking at it from the POCUS angle, when for those of who do lung ultrasounds, many a times you have registrars who can do lung ultrasounds but not echoes. Acute core pulmonale, and even if you look at the blue protocol of Daniel Lichtenstein, is a cause of dyspnea with no B lines. So, causes of dyspnea without B lines one is pulmonary embolism, and then you have COPD, bronchial asthmas. Now, in patients, when you find, if you're ICU patient, so typically if you find in the round that this patient has developed a hemodynamic compromise, and when you're scanning and you find that yesterday was good, but today, the RV appears a little dilated and the interventricular septum is going into the LV and systole. So if the plateau pressures are above 27, kindly bring it down by reducing the tidal volumes. If the plateau pressures are less than 27, but you still find that the septum is denting into the LV, and if the PaCO2 is still high, then you really need to, you can't go up on the tidal volume. You'll have to increase the respiratory rate to increase the minute ventilation, and you'll have to remove the HME filter to reduce the resistance of the airway. PEEP adjustment is extremely important, and this is something which is easy to practice, is how to titrate PEEP, whichever way, whether you are using the ArtsNet table or you're using recruitment maneuvers or incremental, decremental, whatever you are doing. Remember one thing, put a probe at any level of PEEP. If your RV starts dilating and the septum starts denting, it will compromise the hemodynamics. And how it will compromise the hemodynamics, which we will see in the next section of the talk, that is ventricular interdependence. And of course, if the PF ratio is less than 150, you need to prone the patient. So how do we differentiate between acute cor pulmonale, which is a echo diagnosis, versus a chronic cor pulmonale, which is what is taught to us as undergraduates and postgraduates in patients of chronic lung diseases like COPD, ILD. So in acute cor pulmonale, typically you will have interventricular flattening and end systole. In chronic cor pulmonale, you will have an interventricular flattening in systole and diastole, more in diastole. Now, acute cor pulmonale is a pressure overload. Chronic cor pulmonale is a volume overload. In acute cor pulmonale, you will generally not have a significant TR jet. There may be a small jet because the function is acutely compromised. In chronic cor pulmonale, you will have a significant TR jet if the RV function is normal. But if the RV function is compromised, then you're not going to have a TR jet. In acute cor pulmonale, you will have no pulmonary artery hypertension. But in chronic cor pulmonale, PAH will have been established. So when you measure the PASP by echocardiography, you will find that there is a pulmonary hypertension. And in acute cor pulmonale, you will not have a right ventricular hypertrophy. And in chronic cor pulmonale, you will have a right ventricular hypertrophy. So in echo, in the apical four chamber view, we can see the TR jet. From the TR jet, we calculate the PASP, and the RVH we typically pick up from the subcostal view when we look at the free wall of the right ventricle. So now moving on from acute cor pulmonale to the second part of the talk, and that is ventricular interdependence and its implications in critical care. So if you remember this cartoon, and why it is important to remember this cartoon is, this is the left ventricle and this is the right ventricle. So my first question to the audience is, then which ventricle is this little pet over here? Anybody can answer the question. You have the left ventricle, you have the right ventricle, and they are walking away, and the poor pet is running lest he gets crushed. Any takers?
So any DNB students who are there can put their questions in the answer in the chat box.
No, you can call back, or you can talk. We need to, you really need to be very clear who's this person. So you have the left ventricle, the right ventricle. Anyway, anybody?
I think it's the right ventricle.
No, so this is the left ventricle. This is the right ventricle. I'm talking about, what is this? What does this represent? The dog which is running away, or the fear of being crushed. And that is the whole reason I have put this lecture together from my experience. This is the intensivist who will get crushed if he doesn't understand the interactions between the left and the right ventricle.
So it's basically the mediator like pulmonary circulation.
No, this is the intensivist.
Okay.
Had the fear of being crushed. Okay, because if you don't understand what's going on. Anyway, so now we move to, again, so this is a short axis view at the papillary muscle level, and you can see the LV and you can see the RV. This is a non-LV and a RV. And now we look in the basic understanding of ventricular interdependence. So we take a view where we can see both the ventricles together, and the best view is a short axis view at the papillary muscle level. First thing, LV is bigger, no doubts. Second, LV is stronger, no doubts. RV is like a golfer's cap sitting on the LV. And the RV moves largely due to the septal movement. So you have to understand that the interventricular septum is a part of the left ventricle. And when the interventricular septum moves, I think it contributes to almost 2/3 of the contractility of the right ventricle. Therefore, in practical, in real life, when you write a anteroseptal or a myocardial infarction, you presume that there will be some drop in the RV systolic function. Okay, this is one. These are the normal interactions. This is the second slide. Again, we see here again, it's the short axis view, papillary muscle level. This is the right ventricle here. This is the anterolateral and this is the posteromedial papillary muscles. Okay, now in LV, in this view, we look at three things. The LV preload, that is the filling. So if this LV is not filled adequately, you will find that in end systole, it just crumbles and both the papillary muscles, which you can see, go and kiss each other in end systole. We look at the LV contractility, and LV contractility is seen by the force with which all the LV walls come in and do a namaste in systole. LV afterload is actually indirectly represented in this view when you find that there is a LV which appears to contract much more strongly than it would have contracted. So if you see normal hearts, it's running at, it's beating at a particular speed, the rate of moving in, and suddenly you will find, boss, this heart seems to be extra strong and it's moving in with a much more vigorous force. But when it is moving in with a much more vigorous force, it is not crumbling in end systole. So if you have a hypovolemic patient, you will find that the heart beats, it moves in very fast, but the papillary muscles kiss each other in end systole. But if you have gross vasodilatation with relative hypovolemia, you will find that the heart, by God, moves in very fast, but the papillary muscles don't kiss each other in end systole. And of course, as far as this talk is concerned, we look at what is known as the eccentricity index. Now, it is very important that for the eccentricity index, you remember that, one caliper moves from the septum to the free wall, other caliper moves perpendicular to it. This is only for exams, but otherwise in real life, we don't do it. Eyeballing is good enough. So this is what I had shown you, and this is the view which tells us everything about acute corpulmonale and ventricular interdependence. This is the anterior wall of the left ventricle. A common mistake, when we do, because we don't get such cuts. So if I'm seeing this anteriorly, I'll say, array, this is anterior wall, my probe is here. No, anterior wall of the left ventricle is where the LV and the RV and the interventricular septum hits. So this is anterior wall of the left ventricle. Like you saw in the previous slide, this anterior wall had come over here. So be careful before you commit. So this is anterior wall of the left ventricle. This is the interventricular septum. This is the papillary muscle. This is the anterolateral, and this is the posteromedial papillary muscle. And this is how I think things are here. I'm sorry, a part of it got cut out of this slide. Okay, now what happens in acute corpulmonale? This is acute corpulmonale. Asterisk has the magic potion for those of you who have read the comics, and he becomes bigger than Obelix. And magic potion, and this is acute corpulmonale, and that prototype is pulmonary embolism and ARDS. So now we look at these cases. Just a second. Okay, so what happens in acute corpulmonale? There is a acute RV pressure overload. And then this RV cannot handle the pressure. So if RV cannot handle the pressure, it is a thin and distensible chamber and it distends. But even after distending, there is huge pressure. So there is a great amount of pressure in the RV cavity, which as such causes a large amount of stress on the free wall of the RV, which compromises the perfusion of the right ventricle. And right ventricle is a chamber which gets better perfused in diastole. But because of the increased pressures in the RV cavity, the RV distends, but despite that, there is a huge stress on the free wall of the RV and the RV perfusion is compromised. Similarly, this stress is also evident on the interventricular septum, which gets pushed into the LV. The moment the interventricular septum is pushed into the LV, the size of the LV cavity becomes small. I agree that the push is most prominent in end systole, but it is also present to some extent in mid systole, and the right ventricular pressures can exceed the LV pressures initially in systole and later in diastole. But even if the RV pressures exceed the LV pressures in mid to late systole, two things happen. One is that the left ventricular intracavitary pressures, they rise, and the left ventricle, by virtue of being pressed from outside, it becomes stiffer. The moment the left ventricle becomes stiffer, the left ventricular pressures go up, and therefore in diastole the filling of left ventricle goes down, because the gradients between the left atrium and the left ventricle are reduced. So therefore the left ventricle preload reduces. And the second thing is, if the left ventricle preload or the filling is reduced, the left ventricular stroke volume also reduces. So therefore, if you are thinking of a pathology of right ventricle like a pulmonary embolism, remember the following: RV systolic function goes down because the RV stroke volume is blocked. RV diastolic dysfunction occurs because the RV is pressure overloaded and the dam walls are stretched out. LV filling is compromised because the LV cavity is pressed from outside and the intracavitary pressures go up. And since the LV filling is compromised, the LV stroke volume is also reduced. And in top of all this, there is right ventricular ischemia. So for those of you who want to remember, I can say this is, if you take the LV, exactly like you can say a tamponade of the LV is taking place when the RV distends up. You have to understand this. Don't say ki, because sometimes you ask for an echo, and with due respect, the echocardiographer will write LVEF 60%, RV distended and moving less and all. But try and understand that the LV contractility is maintained, but the filling has gone down, the stroke volume has gone down. So what the hell are you going to do with the contractility other than being misled, that the LV is good? Yes, the LV is good, but like a hepatorenal, the LV is compromised secondary to the RV dysfunction. So this is it. This is the interventricular septum, free wall of RV. Okay, this side is the walls of the LV, interventricular septum. So now we look quickly at the echo findings in acute cor pulmonale. So if I have to objectively see the right ventricular systolic function, I look at what is known as the right ventricular outflow tract VTI. That means I put my pulse wave Doppler just before the pulmonary valve and I get this waveform. This waveform is important for those of you who are interested. You can measure this. This is the time from onset of pulmonary flow to the peak of pulmonary flow, and this is known as pulmonary acceleration time. I'm telling you why it is important, because if a PAT is less than 100 milliseconds, you can think of pulmonary hypertension. But if the PAT is closer to 60 milliseconds, definitely if you are thinking of a pulmonary embolism, it is in. So a pulmonary acceleration time is a measure, is a way of getting the pulmonary artery systolic pressures in patients who don't have a TR jet, or for doctors who are not very good at measuring the TR jet. This is important. The second thing why this waveform is important, and I have not put the trace here, is on this. So this is the pulmonary flow starts, it reaches a peak velocity. So what I'm trying to tell you, if you are driving a vehicle down an empty road, you can accelerate in very fast. But if this time is less, if this time is lesser and lesser and lesser, it tells you that there's a problem. And similarly here, on the downside, if you get a dicrotic notch, that is again compatible with the diagnosis of pulmonary embolism, and it is known as the W-shaped pulse wave Doppler pattern of the pulmonary artery waveform. And when you lyse these patients, you find that the W disappears also. I'm just telling you what are the related MCQs which are there. So that's the importance of pulmonary acceleration time. The other ways to measure the RV systolic function, of course, one is the TAPSE, which we all do when we put the cursor at the lateral tricuspid annulus, and then we see the movement. So remember that the predominant movement of the free wall of the RV is in the longitudinal direction. Therefore, TAPSE actually captures only this longitudinal motion. It is a good surrogate for the global RV ejection fraction, but this surrogate does not work when there is an infarction of the free wall of the RV, or the free wall of the RV is involved in any other pathology of the heart. Similarly, when you put a tissue Doppler here in the same area, you get this measure, which is a measure of the movement of the RV free wall towards the apex, which is known as S prime. So TAPSE, I think we take a cutoff of about 15 to 17, and S prime we take a cutoff of more than 9 as good RVEF. One of the things we measure in these settings is the tricuspid jet. And if we look at the tricuspid jet and if we transduce it, we get the maximum velocity of the tricuspid jet. And if we do a 4V square of the maximum velocity, we get the right ventricular systolic pressures. And on top of it, if we add the CVP, and I will not discuss here how CVP is added, there are many ways you get the pulmonary artery systolic pressures. But remember, the gradients are reduced when the RV function is reduced. So the clinical implication is like this. You have a patient, say your own patient, COPD, Corpulmonale, right heart failure, his PASP is about 65. Last echo, he's got minimal swelling, he gets breathless on say MRC grade 2 and 3. And this time he was good and everything was good, and suddenly he comes with an acute breathlessness. And this time you find ki boss, he's not wheezing also. There's no exacerbation of COPD and he's breathless. And if you look at the TR jet, and if the TR jet, now you are getting a PASP of around 35, 40, which is significantly less than the previous PASP, you presume that the RV function has dropped. And then you objectively look and see if the RV function is dropped. And if the RV function is dropped, then your diagnosis in this patient is venous thromboembolism, unless proved otherwise. 20% of exacerbations of COPD, AE-COPD, are due to venous thromboembolism. So these are the clinical practical implications. Now we look at a slightly more difficult topic, which I have put it here. So if in this ventricular interdependence, I have told you that the LV gets a lot of pressure from outside and therefore it becomes a very stiff chamber. So if it becomes a stiff chamber, how do we realize it? So for those of us who do this, it's good. For those of us who do only MCQs and not echo, for them also this is good. So if you look at the mitral inflow from the LA into the LV, the first wave is known as the E wave, which is the early filling, and second wave is known as the A wave, which is a atrial contraction. So if you have a nice healthy LV, it will open up every time and it will say le pani dal de, and the E wave will have a nice robust velocity and A wave will be always lesser than the E wave. But as the LV becomes, the LV relaxation gets impaired, it becomes a little stiff, the LV pressures go up, and then it's like filling air into a football now, which is half full. It's not so easy. So that E wave velocity comes down because the LV filling pressures are high, and the A wave has to work much more to contract and push more blood into the LV. So this is the grade 1 diastolic dysfunction. But let's forget that. Let's look at the relationship between the E and the A. Okay, so what I'm trying to tell you, if suppose you had a patient who had who was good, I mean, as a young person who went some time back, he was post-COVID, he got an echo was normal, echo said E by A ratio is 1.2. Now this guy comes and you're suspecting a venous thromboembolism, and you find that the E by A ratio instead of 1.2 is actually, it's about 0.6 or 0.7. What does it tell you? It tells you, boss, that it's 0.3 here, that the filling of the LV is getting compromised. So if this guy has got a dilated RA, dilated RV, flattening septum, it tells you that the LV has started getting stiffer and the LV filling is compromised. The other thing what I'm trying to tell you is that, these pressure patients will get breathless very easily. They'll have high left atrial pressures or left ventricular filling pressures. But if they are hypotensive, you may need to give them some fluid because they are not hypovolemic. They're just getting breathless because the LV pressures are increasing because of the stiffness of the LV and not because of volume overload of the LV, as is typically seen in the prototype cardiogenic pulmonary edema. Then if the LV gets more stiff, you find that the LV pressures are rising. So because of the rise in LV pressure, this rise is also transmitted to the LA. Therefore, you find that now the LV pressures are up, the LA pressures are up. Therefore, the E wave velocity increases to a certain extent. And I'll not discuss this in detail. And then after some time, you find that the E wave has become much bigger than the A wave. That means the E by A ratio typically has become more than 2. That means the LV is compromised. It is stiff to such an extent that the E by A ratio has become more than 2, right? So here what happens is, if the E is less than A, it's known as grade 1 diastolic dysfunction. If the E by A is almost the same, grade 2. If E by A is more than 3, it's grade 3 diastolic dysfunction. So if you call a cardiologist, he will write the grades of diastolic dysfunction and go. But if you call an intensivist who does echoes, he will tell you, boss, पहले तो filling was compromised, E was less, but now the pressures are going up and now the pressures are very high. So therefore, definitely this patient will be breathless. He may have a low PaO2, but he may or may not be hypovolemic in a setting of acute corpulmonale, because this pressure on the LV is not because of the disease of the LV. This changes in E by A patterns are because of the extrinsic compression of the LV and not because of the diseases of the LV. So for the purpose of cardiology description, they can be written as grade 1, 2, 3 diastolic dysfunction. But for the intensive care, it just tells you that the filling pressures of the left side of the heart are increased. That means your acute corpulmonale is by God significant. So, you have many settings for those of us who deal with pulmonary embolism, that you may have a situation where, you see all this, but the patient is not hypotensive, he's still normotensive. So those of us who stick to the guidelines will say, boss, no time for thrombolysis, no, still not a candidate for thrombolysis. So, he's got an acute corpulmonale, that the LV pressures are high. So therefore, if this patient gets hypotensive, the moment you give him a little more fluids, he'll just go into frank pulmonary edema. Therefore, this is a candidate who may better come out with a reperfusion strategy, provided the criteria like, the troponin is left or the RV dysfunction worsens. So this is how you objectively do. So you cannot say that this is right heart failure, I will not give fluids. No, patient has got elevated left ventricular filling pressures. You can just give him a small fluid challenge to see if he can tolerate it. Of course, we don't do the pulmonary inflow patterns, but pulmonary veins flow into the left atrium. So if the left atrium pressures are high, the systolic wave gets compromised. I will not go into this further. And then we come to the last part of the LV is that how does it affect? So I've told you that the LV becomes stiff, not because of a disease producing diastolic dysfunction, because of an extrinsic compression. And therefore, how we do the filling pressures of the left ventricle is we take the velocity of the E wave of the mitral inflow pattern and we check it out with the velocity of the E prime of the tissue Doppler across the mitral annulus, medial aspect or a lateral aspect. I will not go into that. But remember, E by E prime is one of the best ways to measure non-invasively the left ventricular filling pressures or the left atrial pressures. E comes from the mitral inflow pattern. That means the blood flowing across the mitral valve into the ventricle. And E prime actually comes not from the blood flow, but from the movement, the speed of movement of the mitral annulus towards the cardiac apex and back away from the cardiac apex. Okay, so if it's a good heart, it will contract well, it will relax well. If it's a bad heart, it will not contract well. So many of you who measure, this is known as the S prime of the left ventricle, and it will not relax also. So, you know, your relaxation wave, the E prime, will not be this big, it will be small. So tissue Doppler tells you the speed of movement of a tissue. Good tissue moves fast towards the apex and comes back fast to the baseline. Bad tissue moves slowly towards the apex and comes back slowly to the baseline. So you see how we have started in a setting of acute RV dysfunction. We are navigating the left ventricular filling pressures, and I'll tell you why it is important. So therefore, in any critically ill ventilated patients, and even if it is acute cor pulmonale, if you have a septal E prime of less than 8, that means this is a heart which is relaxing very slowly, you know, and this indicates that there is a LV diastolic dysfunction. That means I will tell you, for the outpatient cardiology, LV diastolic dysfunction can be LVH, sarcoidosis, amyloidosis, aortic stenosis. For the intensive care unit, a left ventricular diastolic dysfunction, one, of course, in a setting of sepsis, the heart is known to become stiff and it can have its own impaired relaxation and increase in stiffness. But in intensive care units, we see what is known as other causes or extrinsic causes of LV diastolic dysfunction, say pressure from a dilated RV, especially pressure overload of the, or during cardiac tamponade. You know, when there is a extrinsic pressures, these pressures go up. And of course, we will not grade them in the intensive care unit. And in the ICU, we always look at E by E prime. If it's more than 14, it tells us that the left atrial or the left ventricular end diastolic pressures are elevated. Okay, so this is very clear. So when you are managing the RV, you also have to realize what is happening to the LV. Okay, we may not treat, because here the LV is not the primary pathology, the RV is the primary pathology. So either you thrombolize, or you do a catheter based lysis, or you do a embolectomy, your LV function will automatically improve. Okay, but there are some implications which we will see. And last part is, how does it affect the LV systolic function? So we measure the systolic function by the LVOT VTI, which we take in the apical 5-chamber view. Normal is about 20, and you find that as the pulmonary embolism physiology worsens, you will find that the LV stroke volume goes down. But still, if you get a cardio, the diagnosis will be LVEF 60%, because EF is 60%. We are not interested in EF. Why is the LV stroke volume going down? Because the LV preload is going down. The LV filling is going down. Can you increase the LV filling by giving fluids? Yes, I can increase the LV filling by giving fluids. What is the harm? The potential problem? The potential problem is that the LV filling pressures are very high. If I give even a small amount of fluids, the patient is high risk to slip into pulmonary edema. Of course, we look at fluid responsiveness of the LV. And this is how, so for the LVOT VTI, those of who are seeing, if you reduce the sweep speed, that means instead of capturing 1 or 2 loops, you are capturing about 10 loops over here, and you see the swings. I'm not discussing it in detail. Why I'm showing you this image is a particular reason. You see the swings. So for those of us, I'll read it the other way. Sir, what are dynamic markers of fluid responsiveness? So dynamic markers of fluid responsiveness, one of them is stroke volume variation. How do you see stroke volume variation? You see stroke volume variation on the echo by the swings in the LVOT VTI. Name some causes of false positive swings in the LVOT VTI in echo where the patient is not fluid responsive, and the answer is right heart failure. The reason I'm showing you this is, don't jump and give fluids if you are seeing this. In every patient of right heart failure, you will find that there is an increase in swings, and which is known as a false positive stroke volume variation on echo or on Vigilio, or a false positive pulse pressure variation, as you will see on an arterial line. So therefore, the last 3 concluding slides is ventricular interdependence in acute cor pulmonale. If acute RV dysfunction is present, check whether it is pressure or volume overload or contractility of the RV. Remove cause of pressure overload, that is the afterload, by tackling pulmonary embolism, reducing the PEEP, reducing the tidal volume, and IAP is reducing the intra-abdominal pressures. If volume overload, give diuretics to tackle volume or preload overload. Use inopressors as temporary support for reduced contractility. Fluid responsiveness for the LV is not reliable in this setting as the pulse pressure variation may be false positive. Now, for those of you who attended yesterday's webinar on fluids from the ESICM, there's something I learned. So what they say is, if you have a right heart failure and if you are getting these swings in PPV and SVV, there is a possibility it may be false positive. There is a possibility it may not be false positive. So what you do a passive leg raising. Now, if you do a passive leg raising, so in a case of right heart failure who has got swings in PPV more than 10-12%, and if you're doing a passive leg raising and the swings in PPV are coming down, that means by God it is a correct increase in the swings of PPV. But if you do a passive leg raising, and which is like a endovascular intrinsic fluid challenge, and you find that despite a fluid challenge of passive leg raising, the swings in PPV are not coming down, that means these swings are not related to fluid responsiveness, they are related to right heart failure. RV dysfunction pushes the septum into LV. This reduces the LV and diastolic volume. It also produces LV diastolic dysfunction as it makes the LV more stiff. Hence, LV diastolic dysfunction results in an elevated left atrial pressure even if the LV filling volume is low. So therefore, measuring the pulmonary artery occlusion or the wedge pressures from a Swan-Ganz catheter may not give a true picture. And this happens in post-operative cardiac surgical patients. It may not be a venous thromboembolism. Sometimes you have when you have a Swan-Ganz and you are treating pulmonary edema because you are finding, boss, PASP is 25/15. Now it has become 40/20. And therefore, give diuretics and do this. Actually, when the problem is something else, it is something else which is driving the rise in POP. Therefore, don't go up on the false pathway. So in a post-op cardiac surgical setting, if you're getting a rise in in the pulmonary artery wedge pressures or the PASP, you're getting a rise in the CVP because they are all monitored then always think of a tamponade, something similar, it's compressing it. Use echocardiography to detect LV and RV and diastolic volumes. This will give a better correlation with PAOP. This interdependence is a dynamic process depending on the trajectory of the cause. Bad ventilator settings, the boss sets it in the morning, your this acute corpulmonale will disappear. Arts developing pulmonary hypertension, you prone the patient or you take him on inhaled nitric oxide or you take him on ECMO, again it will disappear. Okay, venous thromboembolism, you lyse it, it disappears. Therefore, for every respiratory and cardiac compromise, please use echocardiography in association with clinical ABG and lab parameters. I think that is all I have from my talk, and thank you for a very, very patient listening.
Yeah, thank you. Thank you, Dr. Vivek. I think it's a wonderful talk, and I think you have covered everything and in a very detailed manner. And probably the people who are more interested in echocardiography, this is a very good session for them. But most of the intensivists, I think, sometimes do echo as a bedside screening tool to measure the point of care interventions like giving a fluid or or starting a inodrop. So with us, Dr. Pradeep sir. So I just request Dr. Pradeep sir if he can able to demonstrate us some of the few clinical scenarios how echo can be useful in the bedside, whether to start inodrop or whether to give fluids in a very simplified and lucid manner. I think it will be helpful to most of our intensivists. And correlating with the clinical parameters, like suppose in a patient with post cardiac transplant or a patient with cardiomyopathy who is coming on failure, or a patient with ARDS which is getting ventilated, or patient of COPD.
Right. So I think you're talking about whether the patient is, hello?
Yes, sir.
You can hear you.
Yeah. Whether the patient is actually fluid responsive or non-fluid responsive.
Yes, sir.
I think that is the question which you asked. And with this responsiveness, you have it with special situations where there may be abnormal IVCs, but clinically whether the person is fluid depleted or not.
Yes, sir. Yes, sir.
Now, whenever you have a normal heart, that means the contractility is normal, and you have an IVC, I would say the IVC which is collapsible or by eyeballing looks like more than 50% variable. I mean, the difference between inspiration and expiration is more than 50%. We would presume these patients to be fluid responsive. This is a simple one. Initially, dehydrated patients, simple one. The complications arise when you start pumping in fluids. Now, if you presume that this particular patient has given 2 liters of fluids, and after giving 2 liters of fluids, you are still in a fix as to whether more fluids should be given or whether vasopressors should be added. This is the answer which you want from the bedside.
Absolutely.
Now, in this particular case, some of the points we would use are from that beautiful lecture by Dr. Vivek. In that, definitely, we would try to do now a passive leg raising test on this particular patient. And if there is an increase in the diameter, I would say around 12 to 15% over the baseline, it could well indicate that this person could still be fluid responsive. In addition to this passive leg raising test, remember, don't forget to look at the lungs. So if you have a lung pattern when you started with to be of the A lung profile means a dry lung profile. And as you're pumping in more and more fluids, you find B lines appearing. That means the lungs are getting wet. And probably at this point, you've reached probably the up limit of your fluids and you require to give pressors. Now, despite this this is a simple way in which there are no complications in the heart, you can have good PLR raising. If despite this, you feel that the person is clinically underfilled and you want to objectively find out, you would definitely look at the LVOT VTI and the variations, which was shown in a particular slide by Dr. Vivek again. And again, I would say in simple terms, if the variations are more than 12 to 15% beat to beat variations, and like he said, reduce the sweep speed, beat to beat variations more than 12 to 15%, that person is likely to be fluid responsive. If the line is absolutely straight at the LVOT VTI, that particular person is likely to be not fluid responsive and require to add pressors if that person is hypotensive. So I hope that in a nutshell summarizes, it's a vast thing, but I think these are the basic things which we would do. Look at the IVC, look at the variability, not getting a conclusion from the IVC and variability, try a PLR. Not getting a conclusion from the PLR and IVC or variability, look at the LVOT VTI. Another important point, if the IVC is not visualized because of the distension of the stomach or gases or whatever is happening, sometimes we look at the internal jugular vein, and the internal jugular vein distensibility index, it's not compressibility index, it's a distensibility index, which would then give you an idea of the preload responsiveness. And if in these circumstances, you could also do a PLR and look at the jugular distensibility as a response to the PLR.
Yeah, thank you. Thank you, sir. And sir, the same thing applies to the spontaneously breathing patient and mechanically ventilated patient? Or
these particular rules usually, as per all the nomenclature, are in a mechanically ventilated patient. But in our day-to-day critical care practice, I utilize these for non-ventilated as well as ventilated. Of course, it is important that you look at all the parameters together and not only one parameter.
So Gunadhar, if I can just add to that, and I'm reasonably fresh because I suggest everybody should go back and see that yesterday's ESICM webinar on fluids. So passive leg, all these patients, as Dr. DeCosta said, were first validated in mechanically ventilated, sedated, and paralyzed. But for patients who are spontaneously breathing, whether without ventilation or even on a mechanical ventilator, passive leg raising does work. But the point about passive leg raising is that you need to measure a change in stroke volume or cardiac output. So if the patient, either you do it by echo, or you will have to go to what is known as advanced hemodynamic monitoring. That means either flow track or Vigilio, whatever you have in your unit. The second thing is end expiratory occlusion. End expiratory occlusion also works well, but it works well only in mechanically ventilated, sedated, and paralyzed patients. And here, of course, the thing is that the change in cardiac output is so small that you cannot pick it up by echo. So one of the MCQs things I learned later in, you need to have at least a 5 to 10% change in cardiac output to convincingly pick it up by echocardiography. Therefore, if you're doing an end expiratory maneuver, you need to have one of the advanced hemodynamic monitoring gadgets, which gives you a continuous stroke volume variation. Right now, other than that, the third thing is a tidal volume challenge. Now, this tidal volume challenge also works best in mechanically ventilated, sedated, and paralyzed patients. And it also produces a change in cardiac output. But here again, you will need an advanced hemodynamic monitoring gadget. So if we have to do a passive leg raising in a spontaneously breathing patient who does not have anything, we use a echo. If we have to do a passive leg raising in a spontaneously breathing patient who has an arterial line, then we can look at the swings in the pulse pressure variation. Thanks.
So one of the questions is asked by Dr. Sudhi. So basically, she wants to know how exactly is the internal jugular vein distensibility checked, sir, and how does this procedure is performed? Dr. Neeraj or Dr. Deepak, if you can answer this.
I think let
Neeraj, sir.
So it's exactly the same way you check for IVC, you check for the jugular vein distensibility index, but the problem is the percentage is slightly different. And one also needs to understand, because it is in the spontaneously breathing patient, anybody who is actively expiring, you do not do at the end of inspiration, you do it just at the end of expiration, but rather you try to match it when they are about to begin their inspiration, so that the more pronounced effects are not shown in the distensibility index.
And what about the correlation of the downstream markers along with the echocardiography to come to a hemodynamic monitoring for the patient to give a fluid or not? So does the correlation match properly, or you have to only rely on the echo and the other point of care gadgets to give fluid and vasopressin?
I think Dr. DeCosta and Dr. Deep things, if you can take from their talk, is that it has to be a holistic assessment rather than a single parameter. For example, when I have a patient who is an ARDS, then if you're gonna put whatever probe, you're gonna have lots and lots of B lines. No confusion about it. The confusion is whether I can give fluid to this patient when this patient starts to go hemodynamically compromised. So the simplest thing, if you have a good modern day ventilator, is to have a PPV turned on these patients all the time. And anybody who is having reasonably filled up, you will not see pulse pressure variation on the ventilator. The second thing is, obviously, if you are well versed with echocardiography, yeah, you can put a probe, you can look at all those things and all those parameters that Dr. Vivek has described. But I would like to go back to the conventional definition of acute corpulmonale, which is very simple. At the level of papillary muscle, in the short axis, you look at the RV and diastolic area and LV and diastolic area. The moment it is more than 0.6, the ratio, you suspect this patient is having acute corpulmonale. And then you look at the septum. If the septum is shifted towards the left atrium, your patient is having acute corpulmonale. So now we have defined a situation in which I have a patient who is in ARDS, who is hemodynamically compromised, but he's out of bound to fluid therapy because all the sign is having acute corpulmonale. And this is the time probably one needs to look at the therapeutic intervention one needs to do. As Dr. Deepak really beautifully pointed out, there can be certain things which could be amenable to treatment. One of them is setting of ventilator. The study that he was quoting is really important in one factor, that it also sensitizes all our intensivists, that it's not the amount of PEEP we were giving, because those who were on just 5 centimeters of PEEP, they had as much chances of developing acute pulmonale as they were on 15 centimeter of PEEP. So it is the combined effect in that patient that we need to look. And rather than giving in a patient who is hemodynamically compromised any kind of fluid, if they are having right ventricle compromise, it is better to start them straight away on norepinephrine. And then there are certain targets one can have. One is to have your arterial CO2 targets less than 50. You can also try to have your driving pressures manipulated. And if you are ventilating at 8 ml per kg, try to bring it down to 7 ml per kg. So all these things combined, they have an effect, rather going only for a single downstream parameter or echocardiographic parameter, because they are dynamic. For example, your E by A will definitely change the moment you reduce your P from 14 to 10, or it will change vice versa if you increase the P. So rather than looking at one parameter, see how the parameter is changing with intervention. And that's PLR is something which has taught us.
So Gunadhar, that was a very good extension of what I spoke. I just want to say, let's be very clear that there is whatever I have discussed, echo-based hemodynamics is all macro circulation. Okay, and the downstream markers may not improve even if you optimize the macro circulation, if your micro circulation is compromised, which is typically seen prototype in septic shock, and it can also occur in late stages of cardiogenic shock when it gets compromised. So I think the entire talk today is optimization of the upstream markers. Perfusion actually depends on the micro circulation, because that is the final endpoint. So even after doing all this, if your micro circulation is compromised, then either you have not treated the sepsis properly, or if you have treated the sepsis properly, you can go on to using medications which are not part of this lecture.
Yes.
So to simply, one thing would be like, as Dr. DeCosta said, it has to be algorithmic approach. So first you do your preload measurement right. Then you look at if my patient is not preloaded well, but is my patient suffering with RV failure? So which definitely rules out further fluid supplementation despite my patient being LV fluid responsive. RV will not absorb that fluid, which it needs to transit into the LV, period. Then you start with your vasopressors, then inotropes, and all these combined, then you look at your downstream markers and see how they are trending with the change. If this is not happening, go back to your initial assessment, relook what probably got overlooked.
Well, that's fantastic. I have two questions to ask. Basically, if LVOT, VTI index is also very important. E by E prime is very important to diagnose probably LV overload and all that. So if the patient has aortic regurgitation, would these values be reliable, or what is the assumption that we need to have in such circumstances as far as E by E prime calculation is concerned? LVOT, VTI index is also not reliable in this situation. My question is to everyone, I mean, the speaker.
Yeah, so Akhilesh, I'll take that question. So what we discussed, of course, we presume that the valves were normal.
Yeah.
When you have regurgitations, and especially left heart, aortic, and mitral, you presume that you are driving a gadi which is half filled with water, or you are handling a football which is already half filled with air. By virtue of having regurgitation, I understand that there is a volume overload of the left heart. By virtue of this volume overload, if it is chronic, the left atrium and the left ventricle may be enlarged. By virtue of this volume overload, definitely the pressures of the left atrium and the left ventricle will be raised. By virtue of having raised pressures, these patients will be at higher risk of pulmonary edema from something like a 100 ml fluid challenge. By virtue of having these raised pressures, they will not tolerate a distension of the RV as much as a healthy non-regurgitation individual will tolerate. By virtue of having these raised pressures, they will not tolerate a cardiac tamponade. They will become symptomatic much early. And the last thing which I want all intensivists to remember is all these regurgitation patients have false high EFs. So if you tell me grade 2 MR and the EF is 65%, I will not even bother. But if you tell me, sir, patient has got moderate to severe MR and the EF is 50%, reported as normal, no, that means there is definitely a compromise with chronic regurgitations. You know, the heart becomes hypercontractile. Why the hell has the EF dropped? Is this patient relatively hypovolemic, or has there been a compromise in contractility? So that is how I look at it.
To Pradeep D'Costa, you have some difference of opinion?
No, I agree with regurgitant lesions. You have to be very, very cautious, and you should take utmost care in interpreting these values with regurgitant lesions. Absolutely correct.
Your E by E prime does not work with regurgitation. You don't do tissue Dopplers with regurgitation. You will always have a high E wave. You will always have very high E by E prime. You will have high wedge pressures. But I'll tell you, for the intensivist, if the patient has got regurgitation, doesn't matter. I will go by my trends. If I am seeing that the patient is worsening and the filling pressures are increasing, that means definitely there is a problem of either the contractility of the LV or there is a hypervolemia. And if I, as an intensivist, I am finding no, that the pressures are falling. So the typical story I'll tell you, known case of aortic stenosis, not symptomatic or whatever, mildly symptomatic, awaiting a TAVI, now comes in with a urosepsis, right? And when you find that this tight aortic stenosis comes in with a urosepsis and the patient is a systolic of 80. So obviously, if you call up the cardiologist, he'll say, yeah, be very careful, he's got aortic stenosis. But if you have to work as an intensivist, I just open the file and I look at the mean gradients across the aortic valve. If the mean gradients across the aortic valve were, say, 65, now when the patient has come in urosepsis and the mean gradients across the aortic valve are, say, 45, definitely the cause of drop of the mean gradient is hypovolemia, which can be relative due to vasodilatation of sepsis, or it can be absolute due to an ongoing GI bleed. And it can also be due to acute MI which this patient has sustained where there is a drop in contractility. So if you just compare the mean gradients with the previous gradients and if there is a drop, so aortic stenosis cannot heal on its own. So if the gradients have dropped, definitely the patient most probably needs volume if it is a situation for sepsis.
Oh, that's fantastic. We always assume that we have patient with ARDS and he won't be in supine position most of the time. And if I have to do a 2D echocardiography for a patient with the ARDS and who is in prone position ventilation, already on very high PEEP and high FiO2, and suddenly patient deteriorates, and I want to do 2D echocardiography for that patient and just want to assess RARV dilatation or pressure overload. So what will be the best way to analyze which view we should go for in this situation to identify the problems associated with probably RV overload or LV overload?
You can do it with the subcostal view. In the prone position only, just put your hand below and place the probe, you will get it. There was a case report to this. Now I'm forgetting which journal. It was somewhere on the Twitter. It's very easy. And in COVID patients also, we had to do echoes. So you just push, and even when patients are prone, you get some space because the abdomen is not to be compressed. Just push on your hand in the subcostal space, you will get a good subcostal view. That is one view which you can get. Otherwise, you can see from the left axillary and infra-axillary area, you will be able to address the heart. And even from the prone position, you can see the heart. Of course, you can't take measures, but subcostal view works.
Oh, that's fantastic. I mean, we had similar patient who had ARDS and ventilated with prone positioning, and he developed pulmonary embolism. And we had to make him supine and then identify. That was a disaster, but at least luckily we could save that patient. So this is good objective and basically good suggestion. If we can do subcostal view, weaving of the heart, I think that will give you enough idea. But most of the times it's very difficult at times as well. Subcostal view also may not be optimum enough, but yes, I mean, the other areas can also be used, like parasternal long axis view and parasternal short axis view also can be done in prone position. Yeah. So if yeah.
So we have two questions in the this chat box, basically for Dr. Deepak, or if Subhadeep is there. Subhadeep is also our colleague. He is working as a critical care intensivist. So basically, the question from Dr. Masood, is the DNB student. So the question is validity of the LVOT VTI variability in patients with raised intra-abdominal pressure. And so to Dr. Deepak.
Thank you for the question, sir. I would believe, I think Dr. Vivek or Dr. Pradeep sir are the better question, but as I understand, I think obviously any pressures, it will change, and I think you would not depend too much on it. And always my approach would be depends on the clinical situation. So as the pressures in the abdomen increases, obviously it will transmit to the heart, and we will really not depend on it. I would like to hear from the other seniors.
So one of the settings for false positive swings in LVOT VTI is whenever the RV, let's keep it very conceptual and simple. So when the RV outflow is blocked, that poor RV cannot pump out, all these swings, they increase. It does not indicate fluid responsiveness. Means, so normally swings in LVOT VTI are generated because of the heart-lung interactions, which are different in both spontaneously breathing and sedated and paralyzed patients. But in any setting, if the RV is compromised because its flow is blocked, whether it is a venous thromboembolism, whether it's a tension pneumothorax, whether it's a cardiac tamponade, whether it's a intra-abdominal hypertension, there will be swings which do not necessarily connote fluid responsiveness.
And the other question is from Krishna Chaitanya regarding the IJB distensibility reliability in severe ascites. So is the IVC is not reliable in increased intra-abdominal pressure?
I think Dr. Deepak already answered that. Anything which changes intra-abdominal pressure or any pressure which is transmitting to the thoracic cavity, then those KVRC will always hold true.
And so whichever it is, it would be a venous system, I think, as
precisely. So anything which is compromising your pressures, either even in the pleural cavity, there are so many times when you have ascites which is translating into increased pleural pressure. Even then, these numbers, they are not sacrosanct. But yes, remember one thing: if you are looking at the trends, they will give you some idea. For example, what we used to talk about CVP. If your CVP changes after a particular maneuver, it used to be a fluid challenge earlier. It could be a tidal volume challenge now, and the pressure changes in one particular direction. That trend still remains sacrosanct.
So I would just like to add, for all the intensivists, boss body is one cavity. One hand you have intracranial pressures, and on the other hand you have intra-abdominal pressures. There is always a transmission, and you have to understand the concept. So if the intra-abdominal pressure goes up, obviously the cardiac pressures right-sided will go up. And if the right-sided pressures go up, all sequential, the IVC, the IJV, they will all start distending without actually predicting fluid responsiveness. So it is all linked. And I think this concept is coming in a big way, which I wanted to discuss once with Dr. DeCosta actually, but we'll fix it, known as Vexus. I think we just need to sit and discuss, because it is not about doing Vexus. It is about understanding how venous congestion is the cause of spoiling liver, kidney, and other organs and outcomes, rather than the drop in MAP. So, all these pressures are, it is one body. You press my abdomen, obviously this thing, and if I have a massive pleural effusion, so it is like a extra cardiac tamponade. You will, so if I have a massive pleural effusion and if the cardiologist writes grade 3 diastolic dysfunction, and after that you remove 1.5 liter, next day the next cardiologist will write grade 1 diastolic dysfunction. So that is why this specialty is coming for the intensivist, because we are there. So always do the trends, there is no harm. It takes 10 extra minutes, you put the probe everywhere and then go and find the answer for yourself.
I would just extend the same thing, sir, what sir is saying. You see people blaming CVP, and the same venous system is actinic, and they'll be applauding the IVC. So I believe it depends on the rider rather than the ride, actually.
No. And the thing is, I'll tell you, intensivists get blamed. Today, as an intensivist, I have written, say, E by A more than 2. And then the evening, the patient is tapped. Next day morning, Professor Emeritus turns up and he's, E by A is 0.8 only. So, kya hai tere ko? And then, around the hospital, the buzz goes that this guy doesn't know. But actually, what has happened, 1.5 liters of pleural fluid has gone down. So obviously any LV physiology is going to improve. So it is also to protect ourselves, you need to be very clear.
Absolutely. So the next question is for Pradeep sir. I think patient on inotropes and vasopressors can confound our echo assessment, and what is the margin of error in this interpretation? From Ketan, Dr. Ketan Karigwar.
Patients on inotropes and vasopressors can confound the echo assessment. And what is the margin of error? I actually did not understand this question in toto.
I believe if the vasopressors and inotropes can actually influence the direct measurements.
No, it's a wrong question, Ketan.
We do.
So I think this question is extension to what Dr. Deepak is saying. So probably you look at your LV when your norepinephrine was just 2 bites. And then you look at your LV, when your norepinephrine has gone to 25 bites. So your interpretation may change.
And sometimes you get a very falsely high ejection fraction in a presence of more.
I'll tell you. So when we do the echoes by an intensivist, we write a few things. One is the ventilator settings. Second is, so you need to have the tidal volume, the PEEP. You need to know whether the patient is paralyzed. Okay, and you also need to know what is the dose of noradrenaline, adrenaline, vasopressin, dobutamine, because when we are working on those settings as intensivists, we take out the stroke volumes. It is understood that if the dose of noradrenaline goes up, definitely the stroke volume may falsely go up, or it may go down depending if the primary pathology has worsened. Okay, so you have to, even if you see all the performers for ICU echocardiography, patient is on ventilator, yes, no, sedated, paralyzed, yes, no, patient is on vasopressor, inotrope, all that has to be mentioned. And typically intensivists do not mention ejection fractions. We play around with stroke volumes. So we had a patient exactly in our same hospital before, where the morning the echo was done and the cardiologist wrote EF 60%, but unfortunately he did not mention that it was NORAD 15 ml, ADRI 15 ml and vasopressin 2.4 ml per hour. And in the evening when the patient died, everybody said, "Arey, utto EF to 60% ta kaise mar gaya?" Kaise mar gaya? Because EF was 60% and all. So again, see, there is a difference between comprehensive echocardiography by the cardiologist versus a ICU echocardiography. And those of you who want to know, just go to the ESICM website. For the EDEC, there is a free performer. Just download the performer. You know, because all these things change our interpretations.
And if I may add, I think most of the intensivists will agree why we are doing that echocardiography or ultrasound at that particular moment. For example, what Dr. Deepak said, the echo was done to see what in a patient who is in extremis on such high doses of vasopressors. Was it done to rule out pulmonary embolism as cause of hemodynamic compromise? Or was it done to see whether my patient is still having a bit of scope of fluid resuscitation? And when you repeat, it is always advisable to see how much fluid you have pumped in since morning to this patient. Because again, your distensibility indexes, which are validated, but the ranges are slightly higher, or the collapsibility indices, they will vary as per the fluid intake that you have given to the patient.
Yes. So what is the best book to study echo? So Dr. Soni to Dr. Vivek, if you can guide the fellows.
My side, the best book is Dr. Daniel De Baker's book on hemodynamic, echo-based hemodynamic monitoring. On Amazon, it's I think 10,500, almost 8 years after publication. But those of you are interested, just share your Gmail ID with me. I have it on Google Drive. I'll share it. I've shared it with at least 200 people across India. I don't mind sharing it because I got it from one of the European delegates only. So I think that remains the best book. And if you have anything, you can always, post a query and ask. But that is by far the best book.
If I may add, for me, at least at a beginner level, I think listening to the seniors daily, I'm like, try to find a habit of using the echo. I'm like, you need to get that inhibition out of your mind. Try to use that probe, get the machine into your ICU if it's not there, and make as many mistakes as possible. In the morning, again, as you present the patient, you present the echo as well, and try to get beatings from your senior, whatever it may be. And at the same time, I usually give half an hour or 1 hour time in the afternoons to go to the echo room and again learn and come back, so that they'll get both the approaches from the intensivist, one from the proper echocardiographer. And YouTube is actually pretty useful for.
And for the very beginners, there's a beautiful book by Echo Made Easy by Sam Kudora. Sam Kudora is the person who works with Anthony McLean in Australia. It's not very costly. I think it's about 1,200, 1,400 rupees now. So every page has got, like, one page will have plaques view, second will have papillary muscle view, third will have this thing. It's a very good book. It's about, I think, 1,200 rupees. Sam Kudora, Echo Made Easy. For beginners, I said this remains by far the best book.
I would suggest there's a book called Figgenbaum. Now, if people want to actually read the intricacies, and usually there is a CD or an interactive sort of edition along with this book, that Figgenbaum should be the third one. I think you all should be also just looking at once.
Figgenbaum is the Bible, actually. That is one thing. So I think you can start with that Sam Kudora, and you should always, in your free time, even if you don't read Figgenbaum, just see the images and just see what is written below the
images. Are really interesting and very crisp and clear.
Yeah.
Any channels, YouTube channels are available, simplified channels where the beginners can learn?
Yeah, there are, but offhand I don't remember anything, but there are good channels as such. But the best channel is your own echo machine here. Do it, capture it, and get corrected. Do it, capture it, get connected. Till one day you will scare somebody to come in the night and have a look. So first time you may be wrong, second time you will be correct. But but that is the way it goes. Not to be scared at all.
I would just tell an example out of it, sir. As sir was saying, in the night yesterday, Niranjan, my friend, was in duty. So there was another doctor's mother was there, post CA patient. So no one was there on the duty, and he doesn't know the echo proper echoes and all, but we just kept a probe. There was a large tamponade. Blindly we kept a needle, and the patient survived. If there was a fear or there was an inhibition, she would not have survived by the time cardiologist came. I think for the beginners, I think it's pretty important daily to try it an echo machine.
Yeah, today echo has become the armamentarium of intensivist. And just like monitoring your vital parameters, today echo monitoring is very, very important in selected group of patients. I don't say all the patients, but there are high risk group of patients where that the heart functions are compromised or likely to compromise. I think we should use ultrasound as an important tool to assess the hemodynamics also, and overall progress of the patient can also be assessed with the help of today echo. I think it should become gold standard as the clinical practice is concerned. So with this, I think we are already overshooting with the time, and I would like to conclude the session. And I must thank Dr. Vivek, a good friend of mine, for your elaborative and extensive talk on this topic. I know you have done great justice with this, and I've got feedbacks also. And thank you very much for your presence today and deliberation. I would like to hear from you again and again. I would like to thank Dr. Pradeep D'Costa. Hello. Yeah, I would like to thank Dr. Pradeep D'Costa as well for your insights, sir. And it's really worth knowing the intricacies of the 2D echocardiography and ultrasound. I would also thank Dr. Neeraj Tyagi for the wonderful inputs on this topic, very important topic. And I hope the students must have realized how important it is to use 2D echocardiography in your day-to-day practice. And I also thank Dr. Deepak for your presence and insights on the topic. And I also thank Dr. Subhadeep Hussain and hope to hear from you all stalwarts again and again. This is evolving branch. Probably it has not come up in routine practice, but very soon I expect that 2D echocardiography also become a routine practice, like you're monitoring vital parameters. 2D echo parameter monitoring also become very important. And with this, I'd like to conclude, and I would like to hear from all the panelists and speakers in, if you can give some advice to the students in a short, message, like, if you can provide insights. Over to you,
So
Dr.
my one take-home message for all the fellowships and DNB students is that the bedside clinical examination cannot, it should be a complementary to the 2D echo, neither a contradictory, because 2D echo alone give you the values, but it has to be correlated with the current clinical scenario when the patient is in the bedside. So that's why the bedside examination is the more important and most vital. This is my take-home message.
Dr. Vivek.
My take-home message is I'm available, and I think whatever skill sets we have in India, very good. It's just that we have all come up from an informal pathway and not a formal training program. But then I think there's a lot of talent available in India for all of you to pick up and become very good echocardiographers. And you are getting good machines now, like one of the recent ones, which is AI enabled, where you just have to put the probe and it will automatically capture all your LVOT, VTI, EF and other things. So this is the future in US. Most intensivist internal medicine residents, of course there's no PSC, PNT, have their own machines, and which are called pocket rockets, which Paul Mayo told me. And they instead of going for one vacation in one term, they save the money and they buy it. So the thing is, it's there for the future, and this is the weapon which will brand us intensivists as separate from other specialties. See, somewhere in India, you have to realize we are diluted. We come below cardiologists, nephrologists, everything and all. This is a specialty where today, if you put the probe, you can say ongoing GI bleed, you can say Ryle's tube not in place, you can renal failure because the renal resistive index or the venous congestion in the kidney. And there are a lot of us available. Like say, even today, I am learning how to differentiate between large and small bowel loops and pick up, say peritoneal stripes and, free intraperitoneal. I'm trying to master it. So there is a learning curve for everything. And, there is a lot of talent. We have all the resources. You don't have to spend any money. And almost centers in India, the PCPNDT is not an issue at all. Please go ahead, and all of us are available. You can connect with us anytime, and we are there to help you and guide you.
Sure, thank you, Dr. Vivek. Dr. Pradeep.
I would say, and it has been said many times, that this is a stethoscope of the modern century. Yes. But like a previous speaker and someone mentioned, that this has to be in addition to clinical examination, robust clinical examination, a robust evaluation of your lab and lab parameters and evaluations. And if you add the sonography to this, it will give you the best results.
Oh, thank you very much. Dr. Neeraj?
I'll say that we are clinicians first, and ultrasound or echocardiography should be used to answer a clinical question. So as we do with any test, there has to be a pre-test probability. What I'm trying to look, and does what I was expecting is there, or it is something which is unexpected? Because as Dr. Vivek pointed out, there is plethora of information it gives. And unfortunately, we've seen, if we do not know how to interpret that information, ultrasound has a similar, can say, future situation which we face with PAC. That, yeah, there is so much of information, but how to use it. So use it in conjunction with what you are looking at. Try to find hard what you are looking at. And if you don't find it, please go back to the original clinical question.
Really, wonderful insights. Yeah. Dr. Swarna Deepak?
I have two things to say, sir. It has been my pleasure to listen all the seniors, and I learned a lot. And thank you for inviting me. Second thing is a simple thing: fake it till you make it. Try to keep on using it every day, and try to clear off your doubts. And as I think many of the seniors told us, maybe at the end of some time you will become master, and you'll be second to none.
Oh, sure. Yeah, but we should not forget our clinical tools. That is very important. We have seen residents using ultrasound first and avoiding clinical assessment. A number of occasions we have identified, but I think we should follow the right path. Let us follow clinical pathways first and then use these armamentariums when needed and use it judiciously. Don't completely rely on this parameter only. We should have a global assessment. A holistic approach is very, very important when you are trying to read the patient in terms of hemodynamics. So with this, I think the delegates must have had a lot of learning from today's webinar. And I hope to see you, all the stalwarts and the seniors and my colleagues again on the same platform. And learning is an ever evolving. I mean, it's a daily business. I think with this perspective, we'll keep learning and hope to see you again. Today, I would like to conclude and say thanks to you all again and bye-bye for now. Good night. Good night.
Good night. Thank you.
Thank you, sir.
Good night.
Thank you. Good night, guys. Thank you. Bye.
Night.
Yeah, thank you. Thank you.
Good night. Thank you. Thank you.